full blood counts.
Yeah, so thank you for the introduction. I'm going to talk about one of my projects I've been working on since starting in January, and that's whether we can predict the severity of COVID-19 using full blood counts. So just for a quick introduction, at the start of the pandemic, the NHS and other healthcare systems around the world were not prepared for the pandemic, and one of the problems was it was unclear who would develop these severe symptoms. And with limited oxygen masks and ventilators and things like that, it was important to quickly decide who would benefit most from this intervention. And so our idea is to use full blood counts taken at admission to hospital to see if we can predict who is going to be the severe patients and potentially who's going to die from COVID. And so to categorize the COVID severity, we use this published A to E classification, which is 5 categories of clinical severity. So A and B are the healthcare workers, and other members of the community that are asymptomatic and have mild symptoms. And then the C, D, and E are those that are hospitalized due to the COVID. C being those that didn't need any extra oxygen through masks. D being those who took supplementary oxygen in masks, and E those that took the most extreme methods, so ventilators and things like that. So why full blood counts? As Daniel said, it's the most common medical test with 3.6 billion a year globally. And this is a test that's done all the time. So most patients who are admitted to hospital get a full blood count taken on day 1. And also there's publications showing we can diagnose COVID-19 using just full blood counts. And the data set we've been using is the EPICOV data set, which was created for COVID-19 research. And this is a data set of about 500,000 Addenbrooke's and other Cambridge hospital patients with test results, including full blood counts. And so I found 4,000 of these patients who tested COVID positive while in hospital, and 83% of these had a full blood count in the first 24 hours. So I classified these using the C, D, and E classification, using the data and what was written in their notes. And these graphs show the number in each class, and the one on the right shows the weekly number. If you can't see it, C is the lightest and E is the darkest at the bottom. And so I removed anyone who was admitted more than 2 days before testing positive, because they were being tested so frequently, they'd likely picked up COVID while in hospital. And I also removed patients who were clearly being admitted for other reasons, such as dialysis. And I only included the patients who did have a full blood count in the first 48 hours. So for some quick preliminary results, I took the first full blood count for each patient and tried to create a classifier for C versus D versus E. And although it's better than the random guessing, it's not as strong classification as I hoped, but I realized that it was the D class that was struggling to disentangle this from the C and E. And so just creating a classifier on C versus E is a much better results. And the graph on the right sort of shows that the eosinophils and the neutrophil counts are the ones that are leading these classifications. I also wanted to go further into group B. And so from the 600 patients I had a full blood count at admission, roughly half of these had died. And I was wondering whether I could classify the death versus recovery. And it actually there is some signal in the blood. And when you consider that these patients are dying 10, 20 days after being admitted, it's quite interesting that you can predict this just from the full blood count taken at admission. And so just for a quick conclusion, there is some good news that there is potentially some signal for this severity. And I believe the signal would be much stronger if we use the raw data that Daniel was talking about rather than the 16 features that the doctors get. But there's of course a lot of bias in this data. So at the moment it's just Cambridge data, which is a very non-diverse population. And so getting other hospitals involved will make sure it works for all sorts of ethnicities and other patients. And also different people would come into hospital at different timeframes. So maybe some people had caught it a few days ago or caught it a week ago. So maybe trying to predict how long ago the contact was made would improve these models. And also there are, of course, still a lot of people in this data set that are in hospital for other reasons and happen to have COVID. So we need to try and tackle this. But yeah, I think that's all I've had to say. Yeah.
Thank you very much.
Thank you.
Our next presentation is going to be from Angelica Aviles Rivero. Angelica, she's going to be talking about multimodal hypergraph diffusion networks for Alzheimer's classification.